Hi guys, good evening. Good evening, good evening. Welcome back to our BLS series. Hi Mansoor, good evening. Hi Osama, good evening. Right, so yeah, hi Rahul. Hi Dangerous World Medical Lecture. Good evening guys. तो आज का जो सेशन होगा, it is going to be quite amazing from a surgeon's point of view. Hi Kohirul Islam. Hi, good evening guys, good evening. So as I was saying, आज का session is going to be a bit more interesting. It is going to be a pure surgeon session. आज हम बात करेंगे only about thyroid surgeries, surgeries and surgeries. We'll talk about the technique, we'll talk about the intraoperative management, the post-operative complication and how we are going to encounter all those problems. So without wasting any further time, let's dig in for today's lecture. Today's topic is all about thyroid surgery. Today's topic is all about thyroid surgery. We'll talk about how to operate, what to operate, when to open, when not to open. And we'll also show you the thyroid surgery video as well. Okay? So every single small point, big point, no point, everything will be covered. Guys, thyroid cancer, I would require 2 hours, so we'll not do it today. We'll do a mega session tomorrow. So that is going to be dealt tomorrow. Okay? Radhe Radhe Vivek, good evening guys, good evening. So all those guys who have tuned up today, आज हम बात करेंगे thyroid surgeries के बारे में. We'll talk about how we are going to approach, कौन सा incision लेना है, क्या position डालनी है, how do you position a patient, how do you expose a thyroid gland, every single thing that we'll be talking about in terms of thyroid surgery. Okay? Now, let's say you've worked up a patient and you've decided that you're going to operate the patient. What are the stepwise procedures that we're going to do? Right? The first thing that we are going to do, I'm talking about we have worked up, we have the diagnosis. We have everything. Now the patient is in the OT theater. What is the first thing? The first thing is going to be the position in which we are going to place the patient. Now, position for the thyroid surgeries, I hope most of us know, it is going to be your rose position. This is going to be a rose position, or also called as the barking dog position. तो barking dog बोलने में अच्छा नहीं लगता है, तो हम rose positions बोलेंगे. ठीक है? So you will give the patient either in a rose position or in a barking dog position. What is this position? So let's say this is the OT table on which we are supposed to take the patient across. ठीक है? So this is the table. Respect the table. This is where you learn everything. You're going to, every single aspect of your life is going to be from this particular context, right? Vivek, is this class for MBBS students? Yes, beta, this is for MBBS students. People, all the students are preparing for their NEET PG as well as for your final year exams, as well as those are interested in learning surgery. That is, all this is for those guys. Okay? So rose position में क्या है? In the rose position, I want the neck to be exposed. Thyroid gland idhar hai, I have to operate in this area, and it's a coveted area. Like if you see this, you can barely see my neck. So I want the neck to be exposed. तो कैसे expose करोगे? See, this is how I'm exposing my neck. So I will have the patient's neck to be positioned in this particular manner. Right, so that there's a hyper extension of the neck is going to be reached. So we tuck the hands behind the head, we expose the neck as much as possible. Now this is done by putting a pillow, or you can say you can put a cushion in the scapular region, right? So you put a pillow in the scapular region, allow the neck to fall in an extended position. So this hyper extension of the neck, so for me, the most important thing that I'm trying to achieve here is this. This is the hyper extension of the neck. If you're able to achieve this hyper extension of the neck, this is what we call it as the rose position, or also called as the barking dog position. This will give me an adequate exposure to the thyroid gland. Once you have put the patient into the position, what is the second step? क्या करोगे? So you have put the patient in a position, there is a hyperextension of the neck is adequately exposed. Now what? Obviously you have to give an incision. So the second thing is going to be the incision of the thyroid surgery. Now the incision that we can give you here is what we name it as the Cocker's incision. In the Cocker's incision, how do you mark it? What do you mark it? I'll also tell you the latest one that we are going to follow as well. Now in the Cocker's incision, if you look at the anatomical orientation, let's say this is the representation of the neck. We have done enough amount of surgical anatomy for all of you to understand and answer me the basic landmarks that we are going to look across here. So you see, this is the hyoid bone that is going to be present right in the center. Then you have your thyroid cartilage. Then you have your cricoid cartilage. Then this happens to be the trachea that is continuous, and this happens to be the suprasternal notch, right? Now, original description of your Cocker's incision. The Cocker said we'll do one thing. We'll take the inferior border of the cricoid cartilage, which is from here. This is the inferior border of the cricoid cartilage. It is 1 centimeter below this. So 1 centimeter below the inferior border of the cricoid cartilage, or you mark it the suprasternal notch. This is suprasternal notch around 4 to 5 centimeters. Around 4 to 5 centimeters above the suprasternal notch, we would give an incision which is going to be in this fashion. So the incision, that is the Cocker's incision, right? The Cocker's incision is the incision that is placed 1 centimeter below the cricoid cartilage, 1 centimeter below the cricoid cartilage, and 4 to 5 centimeters above the suprasternal notch. I will give an incision which is going to be a bit curvy linear, but then we'll open the skin in this area. This is what the Cocker's has described us for a standard incision. Now, what is the latest incision, or the one that we currently follow in our surgeries? Because we are also concerned about the cosmetic outcome, we have already discussed a lot of components where we said that these disorders are more common in females when compared to males. And we all know how much females are concerned about cosmesis, and it is our job to maintain their cosmesis, because at the end they're gonna look good for you guys only. So you want, or you should be taking care of the cosmesis very, very well. Now, again, in the same context, you have the hyoid bone which is present here. Then you have the thyroid cartilage. Then you have the cricoid cartilage. Then you have your trachea. This happens to be your suprasternal notch. Now, this is the trachea that is present here. Now, what we do is, if you see carefully, you will notice that around the 2 to 3 skin creases which are present in the neck. So there is the skin crease which is going to be present in this area. This is the normal skin crease you can see. So when you look very carefully, you can see here there is one skin crease here, there's another skin crease here. There are 2 skin creases which are usually found in every single person. Okay? Now, when you talk about these skin creases, the skin crease closest to the cricoid cartilage, this is where I am going to plan my incision in the skin crease itself. So this is also called as the modified Cocker's, but we don't say the word modified, we say it's a modification of Cocker's incision. See, the objective is to stay close to the inferior border of the cricoid cartilage, because that is where you have the superior border of the thyroid isthmus. That is where you have the superior border of the thyroid isthmus. So currently what we follow the skin crease. We follow the skin crease below cricoid. We will follow the skin crease below the cricoid and then place the incision. So you have 2 incisions that you have. If they ask you specifically what is a Cocker's incision, it is 1 centimeter below the cricoid cartilage, 4 to 5 centimeters above the suprasternal notch. We put an incision, that is what we call as Cocker's incision. But if they ask you which is a preferred incision, currently if you are operating as a surgeon, What would you like to put? I would like to take care of the cosmesis, because all the beautiful women who come down to me for surgery, I have to maintain their cosmesis. That is my moral responsibility, and I will be able to achieve by giving an incision which is going to be this. If you have a female who is more concerned about cosmesis, they don't want any incision in the neck, you can go with two other approaches. One is a transaxillary approach, another one is transoral approach. So what are the other approaches? So this incision is standard, but if I give you as the other option, what are the other approach that you can have? The other approach that you can keep for these patients, the other approach that I can keep for these patients, number one, I can go ahead with transoral approach. This is not that popular. The popular one is your transaxillary approach. So these come under the minimal access surgery. So either you can give a transoral or a transaxillary approach. Let's say you become a hotshot surgeon in future, and you get a client or a patient who is a movie star, and she has a thyroid swelling. She wants to get it operated, but the point is she doesn't want any incision here. So what you can do, you can give her a transaxillary approach, go from here, reach down to the neck, dissect the neck, go to the thyroid gland, remove the gland and extract it, right? So this is how the option that you can be. So patient came to the OT theater. We have given the position that is a coccus, your rose position. We have put the incision that is going to be a coccus incision. Now what? Now each and every intraoperative steps are important. So once the incision is placed, what are we going to do? We are going to dissect through, right? So the third thing that you will do is, after the incision is placed, I am going to raise something called as the subplatysmal flap. I am going to raise something called as a subplatysmal flap. Now what is the subplatysmal flap is? Now let's say this happens to be the neck. We have given the incision. Now as you give incision, the first layer that you open up is going to be the skin. So I have opened the skin. Once you open the skin, right under the skin, you have the subcutaneous fat. Now there is a muscle which is adherent to the subcutaneous fat in the neck. What is that muscle which is attached or which is adherent to the subcutaneous fat? Any idea? There's a muscle that is adherent to this subcutaneous fat, and this muscle is what we call it as the platysma. See, everywhere in the body, you will notice that the subcutaneous fat is free from the underlying muscle, except for in the neck region where it is going to be attached to the subcutaneous muscle. So that is called the subcutaneous muscle. For example, when you contract your hand, does your skin contract? Your skin does not contract. The muscle is contracting, but the skin does not contract. But if you contract here, you can see if I contract my platysma, the skin also contracts. The reason why it is contracting is the subcutaneous fat is adherent to the underlying muscle, and that is what we call it as the platysma. So when you look from outside to inside, the outermost layer that you have is going to be skin. Under the skin, you have the subcutaneous fat. And under the subcutaneous fat, you have the platysma. So what I'm going to do is, I'm going to incise this platysma as well, and then lift that platysma. So hence it is called as a subplatysmal flap. So once you incise this, the end result of this particular step. So this happens to be the neck that we have been operating on, right? I am going to raise the flap. So this is where the superior flap would raise down to, and this is where the inferior flap of the skin. So raising means you have to lift that particular area so that you will be able to reach for the desired site. So this is your flap that we have raised, right? So you see, this is the underlying subcutaneous fat. This is the underlying subcutaneous fat that has been raised across. Along with that, we have also raised the platysma, right? So it is what we call it as the subplatysmal flap. This is what we call it as the subplatysmal flap, right? Now this subplatysmal flap, this subplatysmal flap that you're able to see, give me a second guys, just give me 1 second. Right. So when we say a subplatysmal flap, you can see that we have taken skin into consideration. We have taken skin into consideration. We have taken subcutaneous fat along with it. And then the underlying muscle, that is going to be the platysma. So once you raise this, this is called as the subplatysmal flap. Now what is interesting about the subplatysmal flap is once you've raised it, again the question is, the superior flap should be raised till which point the inferior flap should be raised. So you're raising the flap. You're raising the flap. I've divided the skin here. Now you're pulling the skin up and down. You're pulling the skin up and down. Superior flap to which point? Inferior flap to which point? Remember the superior flap. So this end, if you look at this, this is what we call it as the superior flap. This is what we call it as the superior flap. Now the superior flap is going to be raised to what point? The superior flap will be raised all the way to the superior border of the thyroid cartilage, right? It is raised all the way to that of the superior border of the thyroid cartilage. It is raised all the way to the superior border of the thyroid cartilage, and then you have the inferior flap. This is what we call it as the inferior flap. It is also a subplatysmal flap. The inferior flap, this is going to be raised all the way to the suprasternal notch. All the way to that the suprasternal notch, right? Now if you see here, we have raised the flaps. The superior flap is raised all the way to that of the superior border of the thyroid cartilage. The inferior flap is raised all the way to the suprasternal notch. So if I give you the context here, so this happens to be the hyoid bone that you can see here. This happens to be the superior border of the thyroid cartilage, right? So if I give across here, this is how the superior border of the thyroid cartilage would look like. And this is your suprasternal notch. This is your suprasternal notch, right? So you can see these are the landmarks that we are going to follow. All the way to the suprasternal notch is going to be the inferior flap. The superior flap is raised all the way to the superior border of the thyroid cartilage, right? So once you achieve this, what have you exposed? Now what have you exposed? You have exposed a beautiful set of muscles which are running in a vertical fashion, and that too in a midline. And these muscles, what are these muscles? Any idea? Mansoor, you have already given me the answer. I'm so proud of you. But anybody else, what are these muscles which you have exposed? Now these are what we call it as the strap muscles. These are what we call it as the strap muscles. These are what we call it as the strap muscles. So once you raise a subplatysmal flap, you will now expose a muscle which is running in the midline in this particular one. This is how the muscle is going to run. This is how the muscles in the midline will run, right? And these muscles are what we call it as the strap muscles, right? So the step number 3 is to raise a subplatysmal flap, and we were able to raise the subplatysmal flap. Now once the flap is raised, what is step number 4? The step number 4, it is to incise the strap muscles. It is incise the strap muscles vertically in midline and retract them laterally. Right? So what we are going to do is, I'm going to incise the strap muscles in the midline in a vertical fashion, and then we are going to retract it laterally. Now before that, even if I start the whole discussion, what are these strap muscles, right? So what are the set of strap muscles? I hope everybody, all my guys who are been here, I know that how much you enjoy anatomy, and you know how much I love anatomy. Now, without having a proper knowledge of anatomy, the surgery becomes near impossible. Near impossible? It is impossible, right? Yes, Mansoor, you're correct. You can use a jaw self-retaining retractor, but they are causing a lot of trauma. So now we use something called as a holding pins as well. So you have where you can put a small pin, and then you can suture it to the drapes that you have put across. So they give you a better exposure. It gives you a complete exposure, and it is less traumatic as well than compared to the jaws retractor. Now, what are the strap muscles? Now, in order to understand the strap muscles, you have to understand the same concept here. So this happens to be the hyoid bone that you have. Then you have, this is the thyroid cartilage. This happens to be the cricoid cartilage. This happens to be the trachea. And this happens to be our beautiful suprasternal notch, right? So this we've been talking since the very beginning that we have. Now, strap muscles are the set of muscles which are going to be present between these two. Now, one set of muscle that you can see is going to be between the hyoid. So I'll just label it down for you so that we don't confuse also. This is the hyoid bone, this is the thyroid, this is the cricoid, this is the suprasternal notch, right? So HTCS is what you're going to look across. Now, when you look at the muscles that we're going to talk about, number one, you have something called as the sternothyroid muscle. So you see there's a muscle that is going to be between the thyroid gland and the sternum. So this is what we call it as the sternothyroid. This is what we call it as the sternothyroid. Then there is something called as between the hyoid bone and the sternum. So this is your sternohyoid. This is going to be your sternohyoid that you have. Then you have the thyrohyoid, which is going to be between these two. So this muscle that is present between the thyroid cartilage, between the thyroid cartilage and the hyoid bone, this is what we call it as the thyrohyoid. And then you have another set of muscle which is called as the omohyoid, which runs in this particular manner. So omohyoid, which is, if I show you across, it starts from the hyoid bone, but it is going to run in this fashion. It runs posteriorly. So this is your omohyoid, right? So these are the paired muscles which are going to be present on the either side. I've just shown you a split, but they will be present in the midline right across here, right? So for the sake of understanding, if I label the first muscle that you have between the hyoid and the sternum, this is what we call it as the sternohyoid. This is what we call it as the sternohyoid. Then you have the sternothyroid. This is your sternothyroid. Then you have the thyrohyoid. This is your thyrohyoid, which is here. Thyrohyoid. And then you have the omohyoid. All these muscles put together is what we call it as the strap muscles. Rahul, you are absolutely correct. Yes, there is a mnemonic, but I'm not a great fan of mnemonic because mnemonic always goes for a toss, right? आपको mnemonic याद रह जाएगा, लेकिन mnemonic का मतलब भूल जाओगे. But because you guys are used to mnemonic, I would give you a mnemonic as toss, but don't remember it. Remember these beautiful attachments, right? You see these attachments, they are like a symphony. They're telling your story between the hyoid and thyroid, between the thyroid and sternum, between the hyoid and sternum, between the hyoid and the posterior surface, which goes behind the trapezius muscle. That is your omohyoid, right? So omohyoid has two. Now you have the superior belly and the inferior belly. So that is divided again in the same context. But then these set of muscles is what we call it as the strap muscle. So what we are going to do is we are going to incise the strap muscles. We are going to incise the strap muscles in the midline. Now, once you incise the strap muscle, so how does it look? If I give you a graphical depiction, you take this as the representation. You take this as the representation. Take this as a representation. right? So again, we'll just go through our division. This is how we have exposed it. This is the superior flap. This happens to be the inferior flap. Then you have, this is the subcutaneous fat. Then you have the platysma that is present. And then we had this strap muscles which is present. So this is the arrangement of the strap muscles that we had, right? So this is the strap muscles, and this is how the strap muscles were oriented. So this is how the strap muscle is oriented, right in the center, right? Now once you have identified the strap muscles, so the strap muscles run in their own orientation. So what I'm going to do is I'm going to incise the strap muscles right in the midline. I'm going to incise the strap muscles right in the midline. After incising, I will take the Langenbach retractor. I will put two Langenbach retractors on either end, and then I am going to pull. Now once you are able to pull, what are you going to do? You are going to create an opening right in the center. As you are able to pull, as you are able to retract, you are now able to expose the gland. So you have used the Langenbach retractor. Let's say these are a beautiful Langenbach retractors. So we have used the Langenbach retractors after incising the strap muscles, and once you do so, you expose the beautiful gland that you intend to operate on. That is going to be your thyroid gland, right? So once you incise the strap muscles, you retract them laterally. So what you have done, we have incised the strap muscles. Here we have incised the strap muscles, and then we have retracted laterally. And because of this, we are now able to expose the thyroid gland. Now we are able to expose the thyroid gland. Now once you expose the thyroid gland, this is now your territory. Do whatever you want to. If you want to do a total thyroidectomy, be my guest. If you want to do hemithyroidectomy, whatever you want to do, right? I have given you the gland, I have exposed the gland for you. It is your decision what you want to do, and you can go ahead and do it. Okay. Now, what are the different thyroid surgeries that we have? Once the gland is exposed, now the ball is in our court. What can we do? Now, what are the different surgeries that we have? The first detailed one I'll talk about is going to be your total thyroidectomy. So we'll talk about our total thyroidectomy. So what do you do in a total thyroidectomy? Now, in a total thyroidectomy, you see this happens to be the thyroid gland. This happens to be the thyroid gland that you have. Now, in this thyroid gland, we've already discussed there are following attachments that you have. You have the superior thyroid vein, you have the middle thyroid vein, you have the inferior thyroid vein that you have. At the same time, you have the superior thyroid artery, which is going to come and supply blood to this particular form. And then you have the inferior thyroid artery, which is going to supply blood to the thyroid gland from the inferior pole as well. Now you see we have posteriorly these glands which are called as the parathyroid glands. The blood supply to the parathyroid glands majority of the times are derived from the inferior thyroid artery. You might see the blood supply also come from the superior thyroid artery, but usually majority of the times, 80% of the times, you see the blood supply coming from the inferior thyroid artery. So this is your inferior thyroid artery. This happens to be your superior thyroid artery. These are your parathyroid arteries. This happens to be your superior thyroid vein. This is your middle thyroid vein. And this happens to be your inferior thyroid vein. So you have the entire sets on the both sides. So you will see that again all these veins will be here, all these arteries will be here. For making it clean, I have just depicted in this particular fashion. And now what are you going to do to remove the entire gland? The first thing that I would like to ligate, especially in the head and neck surgeries, are going to be vein. So I would like to ligate the middle thyroid vein. After you've ligated the middle thyroid vein, I will go ahead and ligate the superior and the inferior thyroid vein. There is no exact sequence. We usually mobilize from the superior pole, then go to the inferior pole. If you have to choose one best answer, always ligate the middle thyroid one first. Then you go and ligate the superior thyroid vein. And at the end, because the inferior pole of the thyroid gland is always mobilized at the end, we are going to come and ligate the inferior thyroid vein later, right? The retractor that we are going to use are going to be our Langenbach retractors. We'll show you about the retractors, don't worry about it. Okay? Once you have done, now I'm going to go and ligate the superior thyroid artery, right? So the next structure that we're going to ligate is going to be the superior thyroid artery. We ligate it from the trunk itself. Inferior thyroid artery, I will ligate each individual branch, right? So the last one that we are going to ligate is going to be the inferior thyroid artery. So this is our inferior thyroid artery. See, the difference between these two is, in a superior thyroid artery, I will ligate the trunk directly. That means from the origin itself. As inferior thyroid artery, I am ligating each individual branch. I will isolate with the help of a right angle retractor or a right angle. We have the forceps that we have, and then I'll hook each single one of them. I will ligate them. I can use a bipolar, doesn't matter, but each individual vessel will be ligated, and now the gland will be extracted. Once you do this, so you have ligated all these blood vessels. Once it is done, I am now going to remove this gland. So in a total thyroidectomy, I will remove both the lobes. I will remove both the lobes of the thyroid gland. Along with that, I will also remove the isthmus of the thyroid gland. So if you remove the entire gland in total, this is what we call it as the total thyroidectomy. This is what we call as total thyroidectomy. I hope you understood the concept that why did I ligate the trunk of the superior thyroid artery but the branches of the inferior thyroid artery? The concept is quite simple, because the blood supply to the parathyroid gland usually derives from the inferior thyroid artery. If I go down to the trunk, there's a higher chance that I might cause damage to this vessel, hence causing damage to the parathyroid gland, resulting in post-operative hypocalcemia. I don't want that to happen, so hence I have decided to go ahead with this particular surgery, and this is your total thyroidectomy. Now, next surgery that we have is what we call it as the lobectomy. Now, here is an important thing. We don't have hemithyroidectomy now. The term hemithyroidectomy is obsolete. We only use the term lobectomy. So in the lobectomy, what are we going to do? So we take this as a representation of the isthmus of the thyroid gland. These are the lobes that we have. So in a lobectomy, I will be removing the isthmus of the thyroid gland along with the lobe of the thyroid gland will be removed. So in a lobectomy, it is going to be isthmus of the thyroid gland along with the lobe of the thyroid gland will be removed. This was also known as hemithyroidectomy. This was also, or this earlier was known as hemithyroidectomy. Now we have given it a name as only as lobectomy, right? So now we have a difference between total thyroidectomy and then you have lobectomy. Now there is another term that we now popularly use, is what we call it as the total lobectomy. We do something called as the total lobectomy. So in a total lobectomy, what are we going to do? In a total lobectomy, if you take this as a representation of the thyroid gland, in a total lobectomy, now I am just going to remove the lobe, leaving behind the isthmus and the other side of the lobe. So if only a lobe is removed, only one of the lobe, only if one of the lobe is removed, this is what we call it as the total lobectomy. This is what we call it as total lobectomy. Then comes something called as the subtotal thyroidectomy. Subtotal thyroidectomy. Now, what is this subtotal thyroidectomy? Now, in a subtotal thyroidectomy, so if you take this as a representation of the thyroid gland, in a subtotal thyroidectomy, on the either pole of the thyroid gland, some amount around 4 to 5 grams is going to be left behind, and rest of the thyroid gland will be removed. The rest of the thyroid gland will be removed. So how much it is retained back? Remember, on each pole, around 4 to 5 grams of the thyroid tissue. Around 4 to 5 grams of the thyroid tissue on each lobe will be left behind, and rest of the thyroid gland will be removed. This is what we call it as the subtotal thyroidectomy. So now we have 4 surgeries that we have already understood or described. We have the total thyroidectomy, we have the lobectomy, we have the total lobectomy, and the subtotal thyroidectomy. Is there a more modification? Yes. We have something called as the Hartley-Dunhill procedure. Now, what is this Hartley-Dunhill procedure? Now, there's a various description to this. In a Hartley-Dunhill procedure, in any one of the lobes, some amount of thyroid tissue will be left behind, and rest of the gland will be excised, right? So in a Hartley-Dunhill procedure, this is the thyroid tissue which will be left behind. In any one of the lobe, it is like a variant of subtotal only, but in a subtotal, in either lobes we are going to leave. In Hartley-Dunhill procedure, only in any one of the lobe, some amount of tissue will be left behind. So this varies anywhere between 1 to 10 grams. If you leave a tissue of anywhere between 1 to 10 grams in one of the lobe and remove rest of the thyroid gland, this is what we call it as the Hartley-Dunhill procedure. And the last surgery that you have is what we call it as isthemectomy. The last surgery that you can talk about here is going to be isthemectomy. Now, as we have discussed earlier also, isthemectomy is the surgery of choice to relieve pressure symptoms in a patient who is having an inoperable thyroid swellings, let it be a malignancy or let it be a inflammatory thyroid swellings. If you only remove the isthmus of the thyroid gland, it is only the isthmus of thyroid gland is removed. If you only remove the isthmus of the thyroid gland, this is what we call as isthemectomy. We have already spoken before. Isthemectomy is now currently considered to be as a surgery of choice to relieve pressure symptoms, in an inoperable thyroid swelling. In an inoperable thyroid swelling, this is what we do it as isthemectomy, right? So this gives you an entire context of various thyroid surgeries that we have. So what are the surgeries that we have? You can go ahead with total thyroidectomy or lobectomy. Remember, lobectomy is going to be lobe plus isthmus. Then you have the difference between total lobectomy and the subtotal lobectomy. In total lobectomy, only lobe is removed. In subtotal, small amount of thyroid tissue is left behind on either pole. Rest of the gland is going to be removed. The other two surgeries that you should know, one is going to be a Hartley-Dunhill procedure where some amount of thyroid tissue is left in any one of the lobe. Rest of the gland is removed. And isthemectomy, you remove the isthmus, and this is done to relieve pressure symptoms in an inoperable thyroid swellings. I hope everybody is clear up until this point. All right. So let's go ahead and watch our thyroid surgery. So what we are going to do is, we are going to explain step by step, right? You are going to tell me every single thing, whatever we have described in a beautiful clinical scenario that we gave. I have explained you each and every structure. I've explained you each and every step. Today, I am going to give you that feel of OT, and I'll make you think how a surgeon thinks and how you're going to dissect. Until this point, no, whatever I have made, I've used colors. You know, the muscles are in brown, the gland is in a different color, the artery is in red, the vein is going to be in blue, the nerve is going to be in yellow, and then or what? The muscles are in a different color and shade. Let's dig in and see how it looks like. Okay. Now, what is this incision? We have marked, this is your coccus incision. I've marked 1 centimeter below the cricoid cartilage, 4 to 5 centimeters above the suprasternal notch, right? Now, as it moves across, now I've given the incision, I have deepened. Now you can see as I deep, the subcutaneous fat is opened. Now, once I open the subcutaneous fat, you can see that this white filmy layer that is exposed, and that white filmy layer is your platysma. I am going to incise the platysma. Once I incise the platysma, see here, bang on. Wait. I found something really interesting. Can you see this structure? I hope I should be able to draw a bit. All right, great. Okay, can you see this? Can you see the structure? This bluish structure that you have. Can you see this structure? What is this structure? What is this structure? Platysma kholte hi, pyar se khola platysma, and suddenly I see bang on this. What is this? What is this structure? This is your internal. What is this? It is an internal jugular vein. Okay, so this is your internal jugular vein. The IJV falls right itself here. Sorry, it is an external. I'm saying internal. No, it is an external jugular vein. Sorry. Okay, so this is your external jugular vein, right? It is your external jugular vein. Okay. Now, once you have got this, now I know this is a vessel. It will bleed. Do you want it to bleed? No. So I will secure this vessel and I will ligate. I'm going to ligate this vessel. Okay. Now let's move further. Now I am dissecting it. As I dissected, you have the platysma, you have the anterior interior jugular vein. I am going to isolate. This is a nice, beautiful vein that you have. Now I have pulled the subplatysmal flap. Now this is how I'm raising a flap. Slowly I'm dissecting. I'm lifting the platysma, and this is your subplatysmal flap that we are going to raise. Now once you have raised a subplatysmal flap, see, you can nicely see that you are digging into the neck right now. As I am digging into the neck, I have raised the subplatysmal flap. So, upar utha diya, niche utha diya, the jugular vein which are present on the either side, left and right. Usually, I prefer ligating it because there's no much use. There are other drainage parts that are present. And if you do so, you will be able to prevent a bloodless operative field. This is the midline. Now, I am going to go and incise through the midline, right? Now I'm going to put an incision and slowly open up these strap muscles, right? Now as I incise, so this is the sternocleidomastoid muscle. I'm just delineating it because sometimes the sternocleidomastoid muscle becomes so close that it becomes difficult for us to dissect. So this is just an additional step for mobilization. Okay? So once you have dissected it, now this is where you're opening in the midline, right? So this is your jugular vein that we have clipped. I will usually isolate the jugular vein so that I get it. Now you have exposed the strap muscles which are here. This is a ligosure that we use. Slowly we're dissecting into the strap muscles, and you can see this guy. Where is this guy? Yeah, this is your thyroid gland, right? So slowly I'm going to dissect through. I am incising the strap muscles. I am now going to extract the entire component. Now I am exposing the thyroid gland, right? Now once the thyroid gland is exposed, I will start the dissection from the superior pole and move slowly towards the inferior pole. My immediate and the most important goal is to identify the recurrent laryngeal nerve as well as your superior laryngeal nerve. So I'm going to follow the plane of dissection. This is gently I'm going to draw the tissue out so that I can expose it. Now as I do so, I'll show you. I'm dissecting it gently. See how meticulous the dissection will be. Each and every tissue, before I cut, I will delineate it, I will lift it. Now, if you look at this particular plane, can you see an artery? Can you see a vein? Can you see a muscle? I don't know. Nothing. Everything is red. But I'm telling you, from the surgeon's eye, you will understand that every single structure speaks to you, right? When I first joined my residency, I still remember my first day of surgery where, my seniors were actually operating. I was just standing observing them. And I remember it was a laparotomy case, and they were opening, they said, this is the skin, this is the subcutaneous fat, this is the campus, this is the scarpa. Then they went and they said, this is, the anterior rectus sheath, this is the rectus abdominis, then you have the posterior rectus sheath, then you have the fascia transversalis, preperitoneal pad of fat, peritoneum, and bang into the abdomen. Every single structure they were able to name, for me, everything was just red. I'm like, how the hell are they able to understand, or they're able to even delineate, or they're able to differentiate between these two layers? But trust me, as I continue to operate and as I continue to see those structures, with time, it just evolves. With time, you get more used to it. Now I can have that differentiation. If I'm operating on the lateral abdominal wall, I have a clear orientation, whether I'm an external oblique, internal oblique, or transverse abdominis, whether I'm at the peritoneum level. In fact, this point, I can be very confident that when I put my hand into the abdomen, by the feel of it, I can tell you whether I am feeling the stomach, or is it the duodenum or the jejunum or the ileum, just by the feel of it. And that's what you build up as a muscle memory. And you continue to do so. Your eyes become so precise. How does it happen? I don't know. By the texture, I don't know. I cannot explain, but I'm pretty sure the minute I see, I can delineate that. And the same thing happens in every single surgery. As you continue to do so, you get so much used to it and you fall in love. This is an art form. Right? Not everybody's cup of tea. You cannot dissect this area. You have recurrent laryngeal nerve here. You'll have carotid sheath just next to it. If you open up the carotid sheath, you have the common carotid, you have the internal jugular vein. Along with that, you have vagus. You do not want them to get screwed up, right? So it's our territory. Only a lion can enter. And with a great pride, I'm taking it with a very humble caution. I'm telling you, it takes a lion's heart to dig into these areas and do what we do, right? So I continue to delineate. I will identify each individual structure. I will clip it. And this is where my life relies on. This is my recurrent laryngeal nerve. We have already discussed about the Bayer's triangle of identifying the recurrent laryngeal nerve. You have it. You have the inferior thyroid artery. You can see the overlap. Dissect it gently. Continue to do so. As you go across, you are now going to clip each. See, you are identifying the vessel, clipping the vessel, ligating the vessel with the help of ligashore, which you have here. And then slowly, you will dissect each and every single component, right? I will continue to do so. Still, I identify the superior thyroid artery as well as the inferior thyroid artery. I will see the entire plane of dissection. I will make sure the parathyroid glands are identified. They're pushed away. The thyroid gland is going to be released up. The attachment of the thyroid gland to the trachea will be with the Berry's ligament. I will identify the Berry's ligament. I will ligate the Berry's ligament, gently dissect the Berry's ligament, and now extract the gland completely, right? And once you do so, you will get the end of the specimen. So you have the parathyroid, the cricothyroid joint, you have identified it. Slowly, see, this is how you dissect it. Delineate it, each and every tissue, touch, feel, and then go and excise it. Now you've reached to the point where you have your Berry's ligament. Now I'm dissecting the Berry's ligament slowly. I'm going to lift the thyroid gland from this particular point. Now, as I dissect it one after the other, I will be able to get the gland at the end of it. Okay? We are almost there. We're almost there. We're going to get the gland out. See, I'm showing you one side. We do the same thing on the other side as well. Now, this is what which is holding. This is what we are holding is the thyroid lobe, right? And now slowly, I'll extract it off. I will excise. I'll make sure all the other structures are delineated and the gland is now being extracted out. So this is how at the end you have removed both the lobes and the isthmus of the thyroid gland is delivered. It was a massive goiter that we had and it is excised. So this is how you get oriented to each individual surgery. I know it is quite difficult for you to comprehend, but every single thing that we spoke or I showed you in the video was being spoken here. We spoke about the incision, we did the incision, we spoke about the incision, and then we did a subplatysmal flap. We incise the strap muscles, expose the thyroid gland. We have mobilized the gland, ligated the vessel, extracted. बोलना बड़ा आसान है, करने में असली दम लगता है. ठीक है? So that is where the exact thrill of surgery lies. It's an art form. It just becomes better and better with every single surgery that you are a part of, right? So did you all understand the thyroid surgery? A quick feedback. Did we all understand each and every single component of the thyroid surgery? Okay, chalo. So, all right, ठीक है. Fine. We'll talk about. Achha, we are going to extend the session for another half an hour. I'll talk about the post-operative complications of the thyroid surgery. So we'll be talking about the post-operative complications. We'll be talking about the post-operative complications in a thyroid surgery. ठीक है? बेटा सर्जरी वीडियो में डिफरेंस पता नहीं चल रहा, इसलिए वीडियो बार बार देखो. अभी जो मैंने आपको पढ़ाया है ना, एवरी सिंगल स्टेप उसको पढ़ो, उसको फिर वीडियो में एनालाइज करो. पढ़ो, वीडियो में एनालाइज करो. धीरे 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 ना आपको भी वही सारे स्ट्रक्चर्स डिलीनिएट होकर दिखने लगेंगे. रिकरेंट लैरिंजियल नर्व अलग ही शेड में दिखेगा. इंफीरियर थायराइड वेन एंड इंफीरियर थायराइड आर्टरी अलग ही शेड में दिखेंगे. लोब अलग शेड में दिखेगा. बेरिस लिगामेंट अलग शेड में दिखेगा. और देख देख के आप खुद बोलोगे वाह क्या शेड है. ठीक है? सो दिस इज हाउ यू हैव टू बिल्ड इट अप. ठीक है? इट विल कम विद टाइम. आई नो इट इज अ बिट ओवरवेलमिंग. आई विल शो यू. अच्छा एक काम करते हैं, आई जस्ट टेक अनदर small photo that I have. I'll display it to you. One of my patient only. ये सारे यहीं पे होते हैं. One second. We'll give you a live photo so that you understand better. ऐसा हो ही नहीं सकता कि आपको समझ में ना आए और हम आगे चले जाएं. ठीक है? Just give me 1 second. कहाँ पे है भैया? Okay. So but a practical theory. Okay, I have this another small video about one of the patient that we had. Okay, acha, if you look at this entire component, no, इसको थोड़ा mark out कर लेता हूँ. This structure that you can see here, this is the trachea. I'll say this is the trachea. These are your strap muscles. These are your strap muscles. This is post-operative specimen. See, this is how you have retracted the strap muscles. I have put a Langenbach retractor and then I was able to pull it off. And this is where we had the gland. So we have removed the gland from here. So यहाँ पे हमारा thyroid gland था. इसको निकाल दिया. So this is after extracting the specimen. So now I think here थोड़ा better color format में आपको दिखेगा. If I थोड़ा zoom out अगर मैं कर दूं, if I do a bit of zoom out, you can see this is the orientation. These are the strap muscles that you have. This is the trachea that we have. This is the gland, that the lobe that we've taken out. Okay? It's in a video form that you have. And this is a small drain, no? The drain that you put in the thyroid gland after the surgery. The drain that we put in a thyroid surgery is what we call it as the Romo-Vac drain. Okay? The purpose of putting the drain for a thyroid surgery, it is to prevent reactionary hemorrhage. Okay? Every single component, we'll talk about it. Is it clear? Is it clear? अच्छा रुको. Fine. चलो अब देख ही रहे तो एक और वीडियो भी देख ही लो. I'll show you another video of a different patient. मतलब सेम सर्जरी है। ये जो है ना, ये जो क्लिप्स लगे हुए हैं, ये क्या है, इसका पूरा एक्सटेंशन दिखाता हूं मैं आपको, यू विल अंडरस्टैंड बेटर। ओके, okay, you can see this retractor, you can see there. Okay, so this is your jaws retractor. You see this beautiful retractor that you have. This is your jaws retractor. This is your Langenbach retractor. This is your Langenbach retractor. Langenbach rakha, khicha. And this is your thyroid lobe. You see, this is the thyroid lobe. We are trying to dissect it. So, देखो सबको लाल लाल नजर आ रहा है, ठीक है. But if you understand better, these are your jaws retractor, these are your Langenbach retractor, and this is your thyroid lobe. I'm trying to dissect in the Bayer's area so that I can identify. See, there's a vessel there. This is the inferior thyroid artery. Okay. So again, yes, thoda bahut, you know, that hitchkey is there, but then I hope you will be able to understand. So just have a look at these videos. You will have a bit of orientation, and then we'll build up it across. Okay. Great. So, can we continue? Okay. Hold on for a second. I need a glass of water. Today I forgot to keep a glass of water. Just take 10 seconds and I'll be back. We'll start. बड़ा 1 घंटा नॉन स्टॉप बोलना भी दिक्कत है. ठीक है, चलो. Now, when you talk about the post-operative complications, in the post-operative complications, one of the most common complication that you'll come across is going to be hemorrhage. The most common post-operative complication. So I said this is the most common post-operative complication, that is going to be the hemorrhage. Okay? Now, when you talk about the hemorrhages, we know the hemorrhage can be of primary hemorrhage. Then you have the reactionary hemorrhage. And then you have the secondary hemorrhage. Okay? Now, when we say a primary hemorrhage, is that hemorrhage that occurs on table. So, on table bleeding. So, during the surgery, when it bleeds, it is primary hemorrhage. Reactionary hemorrhages are those hemorrhages which occur within 24 hours of surgery. Which occurs within 24 hours of surgery. Okay? And then you have the secondary hemorrhages which occurs after 24 hours to the upcoming weeks and a month. Within a month, we call it as the secondary hemorrhages. Okay? In thyroid, it is usually that we encounter is going to be a reactionary hemorrhage. And if they ask you what is the most common cause or what is the cause that results in a reactionary hemorrhage, it is usually because of slippage of ligature. Now, all the ligatures, like in our video, I showed you a clip. So you can say slippage of a clip. You put a clip, if it slips. If you put a knot, a ligature, if it slips, it will bleed. Now, when the ligature is going to slip, the question is which ligature usually slips. You have put superior thyroid vein, the middle thyroid vein, the inferior thyroid vein, the superior thyroid artery, inferior thyroid artery. You have put all these ligatures. It is usually the superior thyroid artery ligature. It is the superior thyroid artery ligature, which is the ligature usually likely or most, in general, it is going to slip a lot. The reason is, when you look at the superior thyroid artery, it is like this. The inferior thyroid artery is like this. You are ligating the trunk of the superior thyroid artery. So obviously the blood is going towards the gravity as well as the blood pressure. Everything is concentrated ligature. So the pressure and tension of the ligature is maximum. In an inferior thyroid artery, you are ligating the branches. So once the blood is getting distributed, the volume gets distributed. So pressure becomes less. Second, the blood is flowing in an anti-gravity direction. So the weight of the blood is downwards. The force is upwards. So hence the pressure on these ligatures are much lesser. So it is the superior thyroid artery ligature that usually slips, right? Once it happens, how does the patient present to you? So in a post-operative period, the patient will present to you with a massive midline hematoma. A massive midline neck hematoma will be formed. Along with this massive midline neck hematoma, patient will have signs and symptoms of severe pressure symptoms. There will be severe pressure symptoms, which is also going to cause respiratory distress. So patient will be present in a respiratory distress, right? So you have a midline neck hematoma, there is severe pressure symptoms and a respiratory distress post-operatively. So as soon as the patient is operated, you'll see this. Now imagine that you are the person, or let's say you are the one who has operated on this guy. Okay? Surgery is done, you're going for a post-op rounds in the afternoon. Let's say you operate in the morning, in the afternoon you're just going to the ICU, and suddenly you see a patient who you have operated. No, he's lying on the bed and he's all this choking, like he's in a distress. You can see the respiratory rate picking up, you can see the saturation is dropping down, the heart rate is picking up, patient looks in distress. You walk up to the patient, you look at the patient looks at you. Patient is looking at you because with all the belief in the world, he's thinking that you're going to save him. You're looking at the patient thinking, what the hell is happening with this patient? So patient is looking at you, you're looking at the patient. Patient is looking at you because he thinks you're going to save him. You're looking at the patient, scratching your head that what went wrong. What would you like to do with this patient? There's a patient, you have operated in the morning, in the afternoon, there is a massive midline neck hematoma, patient is severe distress. At any given point, the patient can collapse. The patient can die. You don't have a time. You are the only person who are going to save this patient. So what will we do? What will we do? Option number one, shall we explore it immediately on the bedside? Or I can say bedside evacuation of the hematoma. Option number two, take the patient back to OT and re-explore. Option number three, call for help. You don't know what to do. Option number four, try to stop the bleeding by exerting the pressure, that is external pressure. So kya karoge? Would you like to go with immediate bedside evacuation, shift the patient back to OT, call for help, or put an external pressure and stop the bleeding? What would you like to do, my friend? What is the option? What can we do or what should we do? Right. The answer here, as most of you are giving me a right option, it is your immediate bedside evacuation. Right? Now, if you try to take the patient back to the OT, it takes a lot of time. Here the patient is not going to die without bleeding, the patient will die because of distress. So evacuate the hematoma, put a gentle wick inside, that is stuff it inside with a gauze, put the gauze out, let it drain a bit, shift the patient back to OT and re-explore. Do not try to put an external pressure because already there's so much on distress. You putting an external pressure, you'll definitely kill the patient. Now, that accidental injury would become a murder. Don't do that. Okay? Call for help, beta. In life, you have to remember that once you screw up, there's nobody who's going to come to save you. People will only stand with you when you have accolades. People will only stand with you when you have done something good. The minute you screw up, everybody will like, take care of your own business, right? So I have a very, tricky proverb in my head. I don't want to spoil your head with that. So don't do that. Okay? Chalo. So this is your first complication, right? Can you prevent? So can you prevent respiratory distress? Can you prevent respiratory distress due to hematoma? Can you prevent the respiratory distress due to post-operative hematoma? The answer is yes. I cannot prevent the hemorrhage because that is happening because slip is a ligature and I have put the ligature thinking it will never slip. So it is something which has happened unexpectedly, but you should be prepared for that. That's a sign of a good surgeon. So whenever you have a patient that you're thinking or you have an issue, you should always secure it. So how do you prevent it? You prevent it by putting a Romovac drain. If you want to find out what is this Romovac drain, wait for a series on drains. Every single drain that we use in OT, I will give you a live demonstration. How do we use it? How do we put it? What is the mechanism and how helpful it is going to be for the patient. So when you put a Romovac drain, I'm not saying that it will prevent the hemorrhage. No. But because it sucks all the blood into that drain system, I know the drain is filling up. That tells me that the patient is having an active bleed. It does not cause respiratory distress. With that drain in situ, I can shift the patient back to the OT, re-explore, ligate, and be done with it. Okay? So yes, you can prevent it by your Romovac drain. That is your hemorrhage. The second post-operative complication that you can come across is because or present to you as respiratory distress itself. So what are the causes for post-operative respiratory distress? Number one is the post-operative hematoma that we just spoke about. Along with that, post-operative laryngeal edema. This post-operative laryngeal edema, if patient had a tracheomalacia, we have already discussed it. Malaise means weakness. A floppy trachea under the influence of negative pressure will collapse and cause respiratory distress. So post-operative hematoma, laryngeal edema, there's presence of tracheomalacia, which is going to cause the same issue. Along with that, if there is a bilateral recurrent laryngeal nerve injury, which will cause medialization of vocal cords, hence causing severe respiratory distress. The other complications that you can come across in these patients, number one, there is loss of pitch. The patient cannot modulate his or her voice. This happens because whenever there is damage of the external branch of the superior laryngeal nerve, because these were the tensors of the vocal cords, so hence the pitch cannot be modulated in these particular contexts. That is, there is loss of pitch. Along with the loss of pitch, it can also have hoarseness of voice. Patient can also present to you with hoarseness of voice. The hoarseness of voice occurs whenever there is unilateral damage of a recurrent laryngeal nerve. A unilateral damage of recurrent laryngeal nerve will result in hoarseness of voice. It will also result in post-operative hypothyroidism. That is something that we expect the patient to happen in any patient of thyroid surgery. You remove the gland, so hence it is going to result in post-operative hypothyroidism. And then it will also result in post-operative hypocalcemia. Now this post-operative hypocalcemia occurs usually between the 2nd to 5th post-operative day. Now this occurs due to accidental damage. Due to an accidental damage of parathyroid gland, due to an accidental damage of the parathyroid gland. Now, as a surgeon, you should be able to identify and differentiate between a parathyroid gland and a fat globule, because they both look quite similar, but they are quite distinctly different. Fat globules, they're abundant, they're useless. Parathyroid glands, we only have 4, right? So, normally, intraoperatively, how do you differentiate is, first thing you try to press and see. A fat globule, let's say accidentally have something which is yellow in color in your hand. Okay? Now, a fat globule, it is very easy to compress. Okay? And you try to exert pressure, it blanches away, it will break into pieces. Parathyroid gland, when you try to press, it becomes more red because it is vascular, no? And it is more rubbery. It is more, you know, it has more tensile strength. Okay? It won't break very easily. That's the first thing. Second, ask the sister to give a bowl filled with saline, drop the globule. If it is a fat, it floats. Parathyroid gland is dense, it is going to sink down. This is how you can differentiate it. Whenever you have an accidental removal of the parathyroid gland, do not throw it. It is not yours to throw. It is the patient's, so give it back to him. But kindly put it back on the sternocleidomastoid muscle of the same side in which side you have removed it, accidental removal. Don't try to put it on the brachioradialis of the non-dominant arm, because in the post-operative period, patient will ask you, sir, you took me for surgery for the neck. There is one incision here, one incision here. Kindly tell me what did you remove from here. Now you cannot go and tell that I accidentally removed the parathyroid gland. I put it back in your brachioradialis. Don't mind. Patient will say, okay, sir, I'll not mind. It's not going to happen, right? So be very judicial about it. When you remove it accidentally, put it back on the sternocleidomastoid muscle of the same side. Now that brings down to an interesting story about one of my early part of the surgery where I was doing as an SR and I had a resident. We were operating on a thyroid gland. It was a papillary cancer thyroid. We were able to remove the entire gland. So accidentally I had one of the parathyroid gland which came along with it. So I delineated it. I put it on the trachea. You see the trachea? I put it right here because I wanted to put it back on the sternocleidomastoid muscle. I delivered the specimen. I gave it to the sister and I turned back and I see the parathyroid gland is gone. And I was in a wonder. I was like, what just happened? And I asked my resident कि बेटा यहाँ पे वो छोटा छोटा सा रखा था ना, गोल गोल सा, क्या हुआ? तो his answer was like, सर मुझे लगा वो फैट है तो मैंने सक कर लिया, सक्शन ऑन किया था, सक्शन के साथ ले गया, अब वो सक्शन के साथ चला गया ड्रेन में. And at that point I realized that if your assistant is not vigilant, if he is not attentive, things can screw up. But that was not his mistake. It was my mistake, because I should have educated him. It was my responsibility to educate him and tell him that this is a parathyroid gland, I'm putting it here, kindly take care of it. Because wo bacha abhi resident tha, he was learning, and I thought he's aware. So it's just the surgeon's arrogance sometimes takes over your brain. So you learn all these through your phases. Okay? And then, because luckily he had the other 3 parathyroid glands, so post-operative period was not that problematic. So patient was quite happily went home. But then, you know, it could have happened if, let's say, the patient only had 1 or 2 parathyroid glands and the other were removed in the surgery, that every single gland becomes quite important, because hypocalcemias can cause severe symptoms. Starts with perioral tingling sensation, numbness, then your chovostic sign, then you have carpopedal spasm, which is going to be obstetrician hand, and goes and lands them into severe tetany. You don't want that to happen with your patients. So be very careful and think about how you treat your patients. So before we summarize today's lecture, I have a very important, it's I would say a wisdom that I would like to share with you. See, every single day when we go to the hospital, we go down and look at people. I'll tell you one thing very honestly. Every single person that you meet as a doctor, especially as a surgeon, are the one who are the most, they're the one who are the most pressurized soul, right? They're the one who are being, they've been affected. They've been badly affected. That is why they've landed up to your doorstep. So it's my humble request that every single guy who aspires to become a surgeon, you are going to get a power which is beyond your control. It's superpower. You have the ability to change a person's life, the course of events. You can save a patient, or the patient might die. But that decision, that aura of yours, a patient can live or may die, purely depends upon your dedication, right? So be very careful, learn everything very precisely, be gentle to the people. When they come down to you, they have a lot of problem. Along with that, they are suffering with something which you alone can treat at that particular point. So you have that superpower, right? So just don't take it too casually. Especially when you are aspiring to become a surgeon, my humble request, when you are in the hospital, when you are with the patients, when you are on table, your attention of 100% undivided is required. And that it what takes to be a good surgeon. Forget about being a great surgeon. Okay? So every single day when we see these patients, when they come down, see, we save lives, they're very happy. Sometimes we lose battles. I've seen patients, yeah, obviously when there's the grieving, they will be abusive sometimes. But trust me, 95%, I would say hardly 4 or 5% of these patients I've seen being abusive. 90 to 95% of the patients, whoever I have been with, I've treated, even if you have lost the battle and the patient has come to injuries, because we work in a lot of cancer-based management, 95% of them have been good to us. In fact, they came down to us and said, thank you. You have done everything that was possible. We have seen your efforts. We feel that it was our bad luck, or we feel it was written in our fate that we had to end it this way. But we are okay with it. Okay? So if you put your efforts genuinely, and if you do everything that is possible for your patient in a right sense, you'll always get good. Okay? So be very careful about it. You have a very, very, very high responsibility. Whatever I'm teaching you today, I'm training you for tomorrow. Okay? Having a sound knowledge is not the only thing that is required. You need to get skillful. You need to be a good human being. At the same time, you need to be absolutely passionate. Okay? Have that empathy towards patient. It is important. Put genuine efforts. When you're in hospital, just forget everything. If you cannot disconnect yourself from an outside world, don't enter into that OT, because that itself is a different universe altogether. Okay? With that, I would like to sign off for today. Thank you so much for listening. Tomorrow we'll resume back. We'll do a session which is going to be quite a bit longer. We'll do thyroid cancers and its management, and hopefully we'll do justification to our thyroid chapter. Tomorrow will be the last day for the thyroid, so we'll be completing our first season of BLS, that is going to be thyroid. So we had 9 episodes, and all 9 episodes are dedicated to thyroid. The next week we'll start with a newer episode of BLS, that is going to be a new season, but tomorrow we'll wrap up with the thyroid. Thank you so much for listening. Signing off. We'll see you tomorrow. If any questions, any queries, you know where to reach out to us. You can post it at the Instagram. You have the surgery guy. This is there on the Telegram as well. So we have the Telegram group, the Instagram on the same name. It is by my name, that is Dr. Sandeep Reddy. So in the Spider-Man, he said, great power brings great responsibility. That holds very, very true in our status as well, right? So with that, thank you so much. See you tomorrow. Take care, guys. Good night. Bye. Have fun.